Good evening, everyone, and welcome to the 26th episode of Endocrine Talk Show, a platform where science meets practice. And we deep dive into the evolving dynamics of endocrinology. And tonight, we shift our focus to a topic of critical importance, not just in endocrinology, but in holistic patient care contraception update for the physicians. As a healthcare provider, our role in guiding patients through contraceptive choices extend beyond prescription. We must consider their metabolic, hormonal, and lifestyle profiles, factors that influence efficacy, safety, and overall health outcome, from hormonal contraceptive and their impact on conditions like polycystic ovarian syndrome, diabetes to non-hormonal alternatives suitable for those with contraindication. The scope of discussion is vast and vital. And tonight, we aim to discuss the latest update, clinical insight, and practical tools to better serve to your patient. And to guide us today and moderate our session, we are privileged to have with us Dr. Subhankar Chaudhary. He is an expert endocrinologist. He is serving as director at Department of Diabetes and Endocrinology uh, at Medica Super Specialty Hospital, Kolkata. He is also a former head at Department of Endocrinology, Institute of Postgraduate Medical Education Research, and SSKM Hospital, Kolkata. So with this one, I hand over the digital podium to Subhankar sir and request him to introduce our faculty for today's program. Over to you, sir.
Very good evening. It's wonderful to be part of this program over the last so many months, actually years. And it's been a pleasure actually to have the support of the INTAS team. So this evening we shall talk about oral, not just oral, we shall talk about contraception. And this is, I thought, is an area that we do not talk about much, assume that we all know about it, assume the patients know about it. But I think there are a lot of knowledge gaps and practice inadequacy in this area. So we thought, why not have a quick recap on this area? So this evening, we'll have, as usual, our expert panel to come up with answers to difficult, sometimes not so difficult issues and questions. We thought we cannot do without a gynecologist this evening. So we have Dr. Shushmita Mitra Banerjee, who is a senior consultant obstetrician and gynecologist from the Manipal Hospital in Kolkata. We also have, of course, our endocrinologist colleagues from across the country, and spearheaded by none other than my very good friend, Dr. Arpandev Bhattacharya from Bangalore. Everyone, of course, knows him. So just one word introduction for all of them. So he's consultant endocrinologist at the Department of Diabetes and Endocrinology at the Manipal Hospital in Bangalore. He's also professor of endocrinology at JMM Medical College, JJM Medical College at Davangere in Karnataka. We also have this evening Dr. Altamash Sheikh, who is consultant endocrinologist at the Saifi Hospital in Mumbai. We have with us Dr. Vidya Jagidhar, who has had extensive experience in training in the UK and is currently consultant endocrinologist at KMCH at Coimbatore. And we also have with us, has Dr. Apurva joined, Dr. Apurva Hajirnis, who is consultant endocrinologist at the Harmony Center for Diabetes and Hormonal Disorder at Thane in Mumbai. So we have, as usual, an expert panel, and I would once again ask all of our participants, our audience, to put in your questions in the chat box. We shall try and get as many answers as possible from the panel. While we wait for them to put their questions, I don't see any questions yet in the chat box. So let's start off with, do we have our gynecologist colleague yet? Hi, Dr. Apurva. Good to see
Hello,
you.
good evening, sir.
Good evening. Can't see our gynecologist colleague yet. So let's start with Dr. Altamash. So because it stands to reason and logic that conception should be available for either the man or the woman. But somehow, when we talk about conception, we intuitively think of conception for the woman only. So, what about conception for the male, and why are they not popular or widely used? Altamash. Where is
I think,
Altamash?
sir, sorry,
he's
there
there.
is some network connectivity issue. I'm here.
Okay. Yeah. Sure. Hi.
Hi.
Yeah, bright as ever. Yeah.
Thank you.
So what about, please unmute yourself.
I think I missed out on the question, so can you just repeat that?
Okay. It's about male contraception. So what are the options available? Why has it not really taken off in a big way? Or is it at all possible?
Sure. So audible now. So I'm Dr.
Yes.
Altamar Sheikh. So male contraception, there are various types. One is a barrier method, for example, male condoms. Then we have a surgical method like a vasectomy, or withdrawal method like coitus interruptus, or hormonal methods which are still under research. And also we have some experimental molecules like a reversible inhibition of sperm under the guidance, which is like Vesal gel, which is available. Now, why they are less popular is very interesting. In spite of having female contraception since 1960s and onwards, men, we have one, A is limited option, two, social and cultural norms. Cultural beliefs often place the burden of contraception on women, societal expectations that they should be responsible for a family that was put on the women. Now, this is because of less awareness and acceptance of male contraception. Third point that I would like to highlight is why they are not so popular is fear of side effects. Many men are reluctant to undergo a vasectomy, for example, or to wear a hormonal male contraceptive, for example, within skepticism that it may cause mood changes, decrease libido, or it may affect their masculinity. Point number 4, that why they are less popular, the male contraception, is that lack of awareness and misinformation about male contraception itself. Point number 5 is reversibility. Once I use this particular method of hormone, or once I get this surgical norm, I may not be able to get back to my original masculinity, is what most of the men think. Point number 6, why male contraception is less popular is because of incomplete development of newer methods. Now, I think we have some very interesting articles upcoming by the end of November and December this year, 2024 itself, which will tell us about 2 molecules. I'll tell a little later. What I would want to give a conclusion with this question is that this includes condoms, vasectomy, experimental hormone methods, limited options are available. And because of complex physiology of sperm production and others, men are having fear of side effects and they question on their masculinity. And the research is lagging completely for this particular thing. Maybe 2025 onwards, we have some molecules shoulder to shoulder with a female contraception. Then we take it from there. That's all. Question.
Yeah. Fair enough. Can I ask Arpan a quick one? Is it, theoretically or practically, is it because it's more difficult to stop the millions of sperms developing than stopping one ovum from developing? Does it make sense? Is that the reason why?
I would love to answer this question. Yes,
why the male contraception is difficult? Because every second 1500 to 2000 sperms are produced every second. And to reduce that, you need at least from 100 million, you need to reduce it to minimum at least less than 1 million. You make that man completely oligospermic, if not azoospermic, and then only that effect will happen. So it is easier, if I have to compare a male contraception versus a female contraception, it's easier for a woman to have this thing, because for a woman, it's easier for 2 ways. A, because inhibit the entry of the sperm, and B is inhibit the ovulation itself. So that's why the women methods have been more popular than these.
And there could be social reasons also, as you just touched upon. Yeah, so we come to our most important resource, or one of the very important resource persons this evening, Dr. Shushmita Mitra Banerjee. We've already introduced you before you joined. Thank you very much for coming on this session. So what are the options available for female contraception? Quickly, briefly.
Like we always offer, as we call it, a tray of contraceptives that we offer. Basically, four, mainly the barrier contraception, the regular pills.
Sorry, just to interrupt you, do women actually come for help, advice on conception from gynecologists, or do they just shop around and do this on their own?
Actually, as gynecologists, we really struggle. We try so hard to break this myth of, contraception is the last thing they think of. Probably the newer generation is more aware, but unfortunately, because of the campaigning and everything, they choose the wrong method. That is the emergency contraception. So,
Right.
you go outside any college or in the young girls, there the suppliers say we supply the contraceptive ECs in crates, and whereas the more what should be taken, the contraceptive pill, it is very difficult to sell them. And even if we advise them, they'll first thing will be a no, because of the it's very difficult to break that ice that it is not going to harm them or not going to give them sterility. And the other thing is, the word hormone plays a lot of trick in the mind, so they don't want to have anything that is hormonal, not knowing that it is only we all have hormones and it's only a part of it, that but it's very difficult, and if at all convinced, for a very short term. That is the main problem. And for female barrier contraception, it is very, very difficult, because I think Indian women.
Is that available? I mean, is it available in our country?
It is available. It's also available in Amazon. Only a few, because why I'm saying Amazon is because that is what the younger girls relate to. So, but the thing is, probably Indian women are not very comfortable touching themselves from below. So that is why, when we started the Nuva ring, the ring contraception, or the female condoms, they or any medicine, if we are supposed to give them suppositories vaginally, they are not at all happy. But given pills, because they are still better, and it is always like, either you go for a sterilization, you've had 2 cesareans and they will want a sterilization operation, and or else it is on the, as we were discussing, on the male partner, that condoms is the male condom is what they we understand by the word condom, rather than female condoms. Rather, female condoms used for the anal intercourse is probably not so much discussed about, but can be used, and are used for anal intercourse, but probably that's why it's available. But for girls, it is more about either they have a device put in, like the copper T in the government hospital sectors, public sectors, or the LNGIUS, the Mirena, which is probably, as
LNG is levonorgestrel, right?
The Mirena, we sell it as the trade name. It is, yes, LNGIUS. Right. That is something, because that also, it's more of a medical reason. Then it is also a contraceptive. That is where we have to insert it inside. And once they get used to it, then they are very happy. So previously it was very difficult to convince our girls, but now it is more and more like, if I say that, in the Western world, girls are using it from their early 20s. So it doesn't matter whether you're married, you're unmarried, you want a baby, you've had a baby, you could still go for the LNGIUS. Then probably girls are convinced. So
I mean, in my experience of practice, what I see is Mirena being put at maybe perimenopausal age.
Yes, exactly. I was going to cross the same point.
Yeah,
that is the gynae point. Yes.
Yeah. Okay.
So more for medical reason you are putting rather than contraception reason.
That's 30 plus. When they've completed their family, they're having some menstrual problem. It is very difficult. They in intercourse is sparse and they don't want to go on a monthly pill. So probably they are using condoms when it is offered. And I'm very sorry to say, I have to tell them that, because you're getting it done, it's covered by the insurance. You get it in. If you don't like it, I will take it out. And rather you're convincing somebody that you can take it out and then only they will put it in.
Yeah.
So,
Yeah.
and that is, I can do it in the outdoor. For that, you don't have to
Right.
get admission. So that is
Right.
when they agree.
So this Mirena, is this used as a contraceptive reasonably commonly in our country?
Probably the newer, the girls in their 20s are using it, but
Right.
definitely not the first line. Definitely not.
Right. Okay. So still, the major discussion will be around oral contraceptive pills.
Yes, I would think so.
And what apart from the combined oral contraceptive estrogen progestogen, which we all know, so are there other oral contraceptive pills also widely used?
The progesterone
Progestin only,
pill,
is
the
that
POPs,
used?
yeah, POPs are being used now, and
Okay.
but that needs a bit of counseling because initially it can have the bit of spotting. So if they are counseled well, and either the POPs or the low dose pills, bit of counseling, they do very well. And again, for the progestogen only pill, we see it is mostly for for women who are breastfeeding or who has a gynecological condition, like if you're saying you have endometriosis or you're having heavy menstrual bleed and this is going to help you with that, then probably they're convinced. And then once they see it is working well medically for the gynecological problem as well as for contraception, that convinces them. But most of the time, as I see, it is only for a family planning pill. The POPs, maybe the max is for 4 to 6 months, they're going to use it. And
Right.
because this concept of not bleeding, less bleeding is very alien in our Indian minds. We always still feel that, that the bleeding is very essential and it has to happen in a good volume. And it's all the bad menstrual blood that is getting out of your system. Otherwise, you'll become ill, you'll get cancer, you'll have a bloated tummy. And even if I manage to convince the girls, they go home, the previous generation, they say, no, this cannot be right that you're not bleeding. So
Right.
continuous pills are very difficult to give.
So just I'm being naive. So what is the progesterone only pill that's used commonly? What progestogen at what dose? How is it used?
Right, we have this 24-day pills, and now mostly we are using the dydrogesterone. So
Okay.
and we also used the ES. Like what happens is if we give the 24/4 or 28, if then it's easier for them to follow.
Yeah. Okay. Fine. Good. So still, oral contraceptive pills possibly are most common form that one uses. And why did I? Yeah. So can I ask Dr. Vidya? So what is the mechanism of action of these oral contraceptive pills?
The main contraceptive efficacy is suppression of ovulation by inhibition of the gonadotropin releasing hormone from the hypothalamus. But there's also inhibition of both the luteinizing hormone and the follicle stimulating hormone and the disruption of the mid-cycle LH surge. Both the estrogen and the progesterone in the combined oral contraceptive pill work synergistically to produce this effect, but the estrogen component plays the main role in suppression of FSH and thus prevent follicular genesis, and that is the most important mechanism. Also, estrogen exposure and the pill with a shorter pill-free interval. I don't think so. We have them here. We have the 21/7 with the 7 days is a placebo effect, but with an additional 10 microgram of ethinyl estradiol in the placebo week, or the continuous use of pill results in more complete suppression of FSH and follicular genesis. The estrogen component also stabilizes the endometrium and production to maintain a regular withdrawal bleed. The way the progesterone works is that it works on the endometrium, rendering it less suitable for implantation. And there is thickening of the cervical mucus so that the sperm is not able to penetrate. And also it makes the tubal motility a bit less. So in that way, it provides contraceptive effect.
Right, good. So can we come back to our gynecologist colleague, Dr. Sushmita? So what are the different types of oral contraceptive pills? And I mean, they're different compositions, they're different names, different progestrogens, different estrogens. So does it make a lot of difference? Is it to do with side effects, or is it to do with the effect?
Yes. Actually, so because we have this 4 generations, where first we were using the norethisterone, estrogen, and the progesterone, the norethisterone. So basically that had more of the androgenic effect. So girls were not liking it. And so then we switched over to the second generation, where we were using the levonorgestrel. And then the third generation, where the gestodine and the third generation came in. There's gestrel came in. And then we have the fourth generation now, which we are using. So that is probably because that not only, the fourth generation is what we are not having the androgenic effect, rather, the water retention, the girls have a lot of PCOS now. So the hirsutism are also taken care of acne. So probably that is better used and more acceptable.
Okay.
Because of the side effects, as you correctly said, because of the side effects.
Okay. So maybe we have a couple of questions which we will come back to, but can we ask Dr. Arpandev Bhattacharya, because he's been not used at all over this evening, and he has a very important role to play. So what about non-conceptive use of these oral contraceptive pills? Maybe endocrinologists sometimes use it, others would also use it.
Okay, thank you very much. I think about the first one, which we use for polycystic ovarian, PCOS, PCOM type of picture, where I'm pretty allergic to use the word actually of contraceptive pill. And this is the same thing happening in international forum. I gave, and they tell somebody at 17 years, 18 years, you give a contraceptive pill. That may work very well abroad, but in our country, it doesn't work. I can't tell you mother coming and I'm telling the daughter of 19 that I'm giving. But I believe our clinical use, this is the main one. Estrogen progesterone combination therapy, where only progesterone we do not use for, definitely not for PCOD. Always we use a combined estrogen progesterone one. And for the many advantages, for example, they regularize the cycle, then automatically the SHBG goes off, so your free androgen comes down. And obviously, if people are married, they want to postpone the contraception, then you can kill 2 birds with one stone type of story. So other than that, one important area what we use, or not many use, I see gynecologists using, I think Dr. Sushmita will tell also, in situation like a DUB, we give around 3 to 6 months of therapy. This is our traditional MBBS thing, MBBS one. Now, we are seeing more and more people are transgender, so male to female. We are using estrogen progesterone combination therapy, obviously not to be labeled as a contraceptive therapy, but estrogen progesterone combination. There are certain data out there that in PMS, it can be of help, but certainly this is not an universal indication. Some people with a very significant premenstrual syndrome, they can be used a bit. And again, the third generation on order progesterone, the same thing, the androgenic effect we don't want. Migraine, if the people wants it with the contraception, our initial concept was that if you give estrogen, migraine will worsen. Probably it is not true. Certain cases of migraine, they are actually quite a bit helpful. So certainly estrogen, progesterone, the combination therapy has a good use for the endocrinologist for non-contraceptive reason. That's the way I look at that.
So when you use it for, let us say, PCOS, does it make a lot of difference as to which progesterone you use, progestogen you use? It will theoretically sound better if you used an anti-androgenic progestogen rather than progestogen, which is got neutral action. So is it practically different?
But what is our available? Our standard combination available, what we use mainly is a Femilon type 1 and another one which is along with a cyproterone acetate. So basically,
so cyproterone is supposed to be anti-androgen.
Anti-androgen, yeah. Correct.
But is that any better than a standard estrogen progesterone?
We are not using only estrogen progesterone. Always we'll be using with an anti-androgen, cyproterone acetate. So whichever name you tell available as a Diane or Crimson, so which is our common use, and we try to make them tell that this is what we are using. This is the purpose of it.
Okay, a quick one, a very practical question from Dr. More. Many patients use OC pills to delay period for social issues. What advice we should give to such patients while prescribing OC pills for such purposes, and which option is better? I think we fall back. Yeah, we fall back on Dr. Sushmita. Yeah.
Yes, see, probably that's not the best thing to just postpone the period for one cycle, because
no, but that's the requirement. I mean,
if somebody is coming for it, then if that's a requirement, we normally go for only progesterone. So we are giving.
So when do we start? So and how long can we go?
7 days before the last period date. So if somebody's had it on the 7th of the last month, then we start from first day of the next cycle. And first, supposing if it is 7th May, then we start 1st June next month. And so 7 days from beforehand, we usually started. And then we go up to the day when she does not want, till what date she does not want it. And then a couple of days later, she can stop the period and stop the pill. Then she can have her periods.
What is the maximum, madam? What is the maximum? How many weeks maximum they can take?
See, if somebody is wanting it for a long period of time, then you can go for a contraceptive pill, like 2 packets back to back. Okay. So 21 days back to back, and not using, if that particular brand has that placebo tablets, not to take the placebo tablets, give the 21-day tablet and 21-day tablets back to back. And because after that, the breakthrough bleeding will be more, or they'll miss a pill. So for too long, we normally don't advise, but for at least 3 months, we can give back to back.
Okay.
3 months.
Cycle. Okay.
If we are using the pill. So
and only with progesterone.
Supposing we are using something like Registron, or the commonly used trade names I'm using for you. Yeah. So if we are using Prena, Registron, the only progesterones, then normally we go for 3 weeks, not more than that, 20 tablets.
Yeah. So not more than 3 weeks.
Why that should be. Otherwise, if it's more than 20, then we go for the 21 tablets.
And dose, madam?
Dose, see, nowadays, the problem with what used to happen before, in most families, they know of something called Primuluten, which the grandmother had, the mother had, the daughter is having, and it's kept in the house. Whoever wants it, when they have it. But that has a problem.
That's norethisterone. That's norethisterone? Yeah.
Yes. So, but now what we normally use is any progestogen that we are using, but it can be used in a controlled release. So if we are using the CR, why I'm saying is then the compliance is more, because if they are taking it for 20 days at bedtime, the chances of her remembering are more, putting a daily alarm in the phone or something. rather than missing 1 or 2 pills, which will give her the spotting or bleed, breakthrough bleed. So that is what we normally do for 20 days, and that month is the maximum. Otherwise, they end up having heavier bleeds and they again have to come back to the gynecologist.
Right.
Sorry, can I ask you one more question? What is the failure rate, madam?
Of deferring the period.
Yeah, what is the failure? Suppose there are some puja or some marriages there, and despite taking that, they are getting a bleed. How many times do you see?
Happens, the commonest 2 causes I'll tell you nowadays, because of these single dose medications, the compliance is better, but still they forget. If it's somebody's marriage, on the day of the marriage, they forget. So this is what happens. Either they have missed a pill, or they have not started early enough, or you have not taken a history of how long their cycles are. We assume that 28-day cycles, as I was saying, 7 days beforehand we start. But if they might be having shorter cycles where we have to start before. So that is why but if taken properly, then it should cover, unless they have some pathology, but it should cover.
Okay. So we stay with you, madam. So once we start an oral contraceptive pill, how long does it take to become effective as a contraceptive? And if someone is, and we have a question somewhere from our audience, how to treat, that's slightly different, right? So let's get through that first. So how long will it take?
We start now, the regime is we start from day 1 of periods. So it should cover from the same cycle, because we are not going into the fertile period till day 9. So we get the 7-day period from day 1. Previously, we used to start from day 5. Then it came to day 3 of periods. Now we start from day 1 of periods. So day 1.
Why is that? Why is that?
Because the control is, because we are stopping the LH
from the first
stage. Okay. Yes.
Yeah.
So because we are controlling right from the beginning, rather than leaving it for the 5th day, and then they have to, previously what we used to say, the first cycle for 7 days you use a extra protection like a condom or something, but that we only say if they miss a pill now. So if we miss a pill, then you take extra protection like a condom for the next 7 days. And if you remember it within 12 hours, you take the medication. If you don't remember, then you take the next dose, continue with the box. Don't leave the other medications in between. But for the next 7 days, use a barrier contraception.
Right. The other part is how long after stopping does the girl have to wait if she's planning pregnancy?
So we don't give, it's not that we have to 3 months or 6 months you have to wait, because it's pretty immediate. So the thing is with progestogen only pills, we see sometimes that due to the amenorrhea that they have, sometimes it is difficult to get the first lot of periods on time. So once they are getting the periods regular, they can absolutely try to get pregnant. So there is.
Can I ask one thing? We have the information that ectopic pregnancy is more common, and that is the reason for combined preparation. You should wait for at least 3 cycles without OCP. Is that right?
We don't advise that, based on evidence. The thing that we see is probably with emergency contraception, that EC, sometimes we see more of ectopic pregnancies with emergency contraception, and but for
standard oral contraceptives, you don't.
Oral contraceptive, the normal pills, we once they get back their periods regularly, it should be okay, because once the endometrium is being all right, the egg is being released, so it should be okay.
Right. So the other question, which you had alluded to initially also, is one of the concerns in the mind of the lady. Can it lead to permanent infertility? And we have one of our colleagues, Dr. Mehta, asking how to treat patients who are not able to conceive a child after long-term OC pills.
See, contraceptive pill doesn't do anything which will, permanently cause infertility, subfertility. So I don't see any reason that, permanent, if there was any chance of permanent infertility, then we would have, always taken contraceptive combined pills with a pinch of salt while advising. Because if you see, where it is actually being used and consumed more, not country like India, where it is being dished out from school, 13-year, 14-year-olds, like who are not supposed to take, like rather than waiting till 18 years. It's been given from school, the progestogen pills, then the combined pills, because always the chances, what we are achieving is a contraception, unwanted teenage pregnancies, unwanted pregnancies. So that is, we do use it. It can be used confidently, because if that was it, then most of them, would have become infertile by the time they are actually planning for a family in their late 20s. So after 10 years of use, I don't think we should worry about that.
Right. Okay. Okay. So we'll now come back to an endocrinologist, Dr. Apurva. So we have already got a question in our chat box, and I'll tag that along with maybe a broader question. So the question we have is, it's from Dr. Sharma. Is weight gain with OC pills reversible? So the assumption is there is weight gain with OC pills. And he goes on to say, he or she, as I'm seeing many patients not able to reduce weight once OC pills are stopped. So what are the adverse effects that we see with OC pills?
So first, to discuss weight gain, I think it's one of the misconceptions that OC pills are associated with weight gain. Some of the first generation progestins would give rise to the edema, and the weight was mainly because of the water retention, which is a action of the progesterone. But if we talk about the newer generation progesterones, including levonorgestrel and others, there is no edema, and hence even clinically we see a lot of people not reporting weight gain. Again, when we are using it PCOD, weight becomes an entirely different and patient mixes up. So I think it's very important to address patients' myths about weight. And it is, of course, is no weight gain. And if there is edema and water retention, it is reversible as soon as you stop those OC pills. Now, coming to some of the common side effects of OC pills, sometimes we see mood changes. Again, it is related to the progesterone component. There are certain progesterones like cyproterone, which are associated with anorexia, sometimes fatigue, lot of fatigue, weight loss. So that has to be monitored. Some androgenic, like norethistran containing, may give rise to acne, hirsutism because of the androgenic action. But again, it is limited to when it is used for a longer period and only progesterone rather than the combined OC pills. Then talking about the serious side effects, DVT or venous thromboembolism is associated with OC pills, particularly when estrogen content is higher in older generation, more than 50 micrograms. That is known to cause, or if it is also again fourth generation or third generation OC pills containing desogestrel, rospyrinone. This is an observation that increase DVT risk. Not a side effect, but a common observation is that once a patient is on thyroxine, a hypothyroid patient, and who is on thyroxine, once they are started with OC pills, there is inevitably increase in the requirement of thyroxine medication. So that has to be kept in mind. You can side by side increase the dose of thyroxine medication. And last and most important is migraine. So patients who have migraine, especially migraine with aura, there may be in some of the studies there is slightly increased risk of the stroke associated with, but so that becomes a big contraindication. But migraine without aura, it is safe to prescribe.
But just now we heard that it could be used as a treatment for migraine.
Yes, so some people have migraine, some women have migraine where there is exacerbation in the premenstrual phase, and once we regularize the cycles, and then there is reduction in the chances or the frequency of migraine.
Right. Dr. Arpan Dev, you have such a vast experience. So how often have you seen venous thromboembolism in women on oral contraceptive? Sorry, please unmute.
Myself, no, I have not seen till now. I only read the books.
Yeah, so I could think of maybe one possible instance where she was on oral contraceptive. So what about Dr. Shushmita?
See, we take a history thoroughly before starting the oral contraceptive pill. And if there are no risk factors, then I don't think we should think about VT or I'm yet to see. I don't know, what is the actual thing, but we always say and think that in our genetic loading or our Indian thing, the VT risk is much less than the European or the Western world. Like when I was in UK, like every time we were so worried about VT and every getting the low molecular weight heparin. But if over here you see there are so many women delivering in the unmonitored in the rural areas, in the suburbs over here, and how many times are we using low molecular weight heparin and aspirin? And so I'm talking about the obstetric, which is a very high risk part. So oral contraceptive pill leading to DVT, I'm yet to see as well.
Yeah, I think this is a perfect answer. We are used to see so much in UK, a DVT, and here we don't see only.
Yes.
Yeah.
Can I add?
Vidya.
Yes.
Yeah.
I've had 2 cases of patients who've been on combined oral contraceptive pill
in Birmingham?
No,
or
here in India, in Coimbatore. Referred from the hematologist, because all patients with DVT at some point go under the hematologist for evaluation, and both the patients were on combined oral contraceptive pills. So one patient, both of them had polycystic ovarian syndrome, and the second patient, I'm kind of stuck because it's been 7 months since her last menstrual period, and her endometrial thickness is about 7 mm, and she's not had oral contraceptive pills since her DVT, which was attributed to the pills. So I'm, if we are going to consider the VT risk attributed to estrogen, I wanted to ask Susmita ma'am if it is safe to still give progesterone to induce a withdrawal bleed, or if there is a risk, then should we cover it with heparin for a week and then stop heparin and give progesterone simultaneously to induce a withdrawal bleed? So that is what I would want to put forward to the experts here.
Yeah, because if she's not had her periods for 7 or 9 months, you said, which again leads to this endometrial thickening which is going on. So, we cannot allow that as well for, I don't know, her age or, what her fertility is. So probably what we could do is we could give her a progestogen, the short cycle, 5 days. Every month from day 21 to day 25, we are giving her progestogen. She's had a bleed, and then wait and see, or maybe for 2-3 months, we regularize her periods a bit, and then give a gap for maybe another 6 months. Or if she is not, family planning issues are there, or she has a completed family, then we can use the Mirena coil as well. That is very low dose progestogen acting only inside the uterus.
She's 25, unmarried, and she has lost nearly 6-7 kilos since I counseled her. So she's just the thought of even progesterone. She says, no, I've had a DVT. No. So I was hoping that, given the circumstance, should we give heparin for those 5 days when you're giving progesterone and then stop both and see if she bleeds and or does not get VTA, or is just giving 5-day cycle of micronized progesterone is not going to do her any harm? That was what I was hoping to
Yes.
do, a micronized progesterone,
Yes,
small dose, short cycle to just induce a
Yes,
bleed,
yes, induce a bleed and
giving
leave
her
her
enough
alone
time to
for
lose
some
a
time.
bit more weight. Yeah.
Yeah, because if she's very worried, we don't do much harm by giving her low molecular weight heparin. So maybe if we cover her for a week or so with the low molecular weight heparin and we give her the short cycle progesterone, then we could try that. Yes.
Yeah.
My personal feeling, of course, it's not proven, is the venous thromboembolism on contraceptive pills may be uncovering those with some mutations of factor V Leiden or whatever, which we don't investigate for. Maybe those are the ones
through the
who
hematologist. Yeah, the hematologist had thoroughly
so
investigated for all secondary causes. Yes.
wasn't there, right? Yeah, okay. So we have a question which has been answered. So Dr. Rao, no, sorry, where did we have? So yeah, Dr. Gupta, does oral contraceptive preserve ovarian reserve? So the answer from Dr. Mitra has been no, it does not affect your ovarian reserve, right? Right. So now maybe back to Arpan, endocrinologist. So you have your patient. I actually have a patient of prolactinoma, a large tumor who is the initial prolactin was 5,000 or something. She's been on cabergoline for the last 4 years and up to 3.5 or 4 milligrams in a week, pretty high dose. And her prolactin is still a little bit high, much lower than before, but still it's 170 nanogram per milliliter. And she is amenorrheic. She also had galactoria, which is no longer there, but she's amenorrheic for the last 4 years. So will you give her HRT? Will you give her something? And she still has a macroprolactinoma, much smaller than before. So is there a risk that this will blow up that prolactinoma?
Okay, I'm sure this will be a very challenging situation. The way I'm thinking, the way I would like to tackle this. Firstly, in our from the training period, you heard that estrogen increases the prolactin cells, galactotropes, hyperplasia, and this is more of a, I think, is a physiological and in vitro. We actually don't have a lot of data that my macroprolactinoma increases after we give an estrogen. Now, for microprolactinoma,
but in pregnancy, but
in the
sorry
pregnancy,
to interrupt.
I have to bring that.
In pregnancy, yeah, okay.
In the pregnancy, for example, microprolactinoma, when the pregnancy is confirmed, we stop them. We just observe them. Basically, we don't do anything, including the prolactin level, because the placental prolactin will interfere with the assay, and that will make a mess of stress. But for macroprolactinoma, the standard practice is actually to continue bromocriptine group of medicine, because we know the pregnancy is very safe, and only test practically we do is a visual field, and if necessary, MR scan. But back to your question, now if somebody is not in cycle for 3 and 4 years, we need to get a cycle. So one option will be for me, and I have been trained in the concept that you should, madam is there, you should not go without cycle for more than 90 days. You should be at least having 4 cycles per year. And still, I believe and I tell the people to do that. So one option will be giving progesterone the way madam told. That is fine. But
progesterone, if prolactin high had been the cause, will the progesterone cause a withdrawal bleed? I mean, we could try. We will
try. But giving a estrogen progesterone with a supervision probably will not make a big mess of it. But if somebody is recurring 4 milligram of cabergoline and for 4 years no cycle, but I think we need to tackle the prolactinoma probably in the different non-medical therapy, surgery or something.
But then she is under her prolactin is normal now, isn't it?
Not normal. It's still elevated, but much lower than before. It's still 170. The normal being 25 or whatever. Right. So do we have more questions that we can address? So so the other question that comes to one's mind is how long can we use an OCP, Dr. Mitra?
Nowadays, we don't put any upper limit. So it was 35 years, now it's 40 years. So it is a matter of, we just have to weigh the balance of, whether she wants any other contraceptive method, whether how important it is for her not to get pregnant, and she is aware of the side effects, and she has, she makes her own informed choice. But the recent thing is that we can offer up to 40 years.
And duration in terms of number of years, 5, 10, 15, 20, anything?
Yes,
number of years.
It can be continued. And mostly because what happens is there is a break because they have the minimal bleeding, and they don't, women won't like maybe a spotting a month. So maybe a month break in a year, but that has to be very well assessed, because I have tried and then that month only they've got pregnant. So and that can be a psychological trauma, going through an abortion. Things are, whatever form of abortion, medical, surgical, it is a psychological trauma. And then yes, unfortunately or fortunately, I know in a populous country like ours, I have not prescribed a oral contraceptive pill for, more than a year or a couple of years, maybe. Only very few are very happy with the pills and they want to stick to it. And even same for LNGIUS. The ones who are happy get it changed every 5 years. But that is something we have to see. And
one personal experience, Shubhankar, I've seen, and I made a big mistake and realized that why the hell I told that in UK, lady of 55, and I told, why not you stop this? You are mad, young man. I have started from the age of 15, and you want me to tell the stop the medicine now. I continue throughout my life. Yes. That's the highest I have heard somebody taking for 40 years.
Yes, because they are using as that HRT now. Basically, she's feeling good, and over there, having a cyclical bleed makes her feel young, and basically she doesn't want the hot flushes to come, or the skin aging or whatever.
Yeah, so that brings us back to our endocrinologist colleague, Dr. Vidya. You're there. So given the ease of use and relatively easy availability and cost-wise, I think they're also better placed. Can the combined oral contraceptive pills be used for HRT?
Being an endocrinologist, I would say the indications for oral contraceptive pills are quite distinct to hormone replacement therapy. HRT is something we would use for patients with primary ovarian insufficiency, premature menopause, or patients with perimenopausal symptoms, because the HRT has got the right amount of estrogen and progesterone that closely mimics our physiological estrogen and progesterone. And also in primary ovarian insufficiency helps with bone protection. But oral contraceptive pill have got superphysiological levels of estrogen and progesterone, and it is best to use them for contraception or regulation of cycle rather than use it for hormone replacement therapy, because as we already discussed with HRT, primary ovarian insufficiency patients are going to need estrogen and progesterone long term. So there's no need to give a very high dose of oral contraceptive, estrogen and progesterone in the form of OC pills, where the side effect also can be more.
Yeah, sure. But also, we are in the era of the low dose pills.
Yes.
Yeah, I mean, so 20 so the low dose estrogen. So how far away is that estrogen dose from what you would prescribe in HRT?
We only need 5 microgram of ethinyl estradiol, and the lowest one that we have still has got 20 micrograms. So we still 4 times more in the oral contraceptive pills. We do not have the very low ones that we get in the hormone replacement. And also with oral contraceptive pills, they have the pill-free period where 7 days they don't take any pills, and that's the time where they can have all the menopausal symptoms as well. So if the patient can afford, I think we should still give the hormone replacement therapy. If not, the lowest dose of the 17-beta estradiol followed by micronized progesterone every 3 months or so to help induce period. That is what we usually give for patients who cannot afford a hormone replacement therapy.
Absolutely, fully agree.
For
Yes.
the hormone replacements that we are using now, we use the other forms of the estrogen as well, the estrogen hemihydrate.
The patches and the gels.
Patches, gels, yes, patches,
Yes.
gels, and like in the liver patches, then we can skip the liver metabolism.
Yeah.
So that
Right.
is good. But I
The
agree
patches are a lot,
that
yeah.
these are really expensive. And that is why probably the lower socioeconomic group, that they never ask for it also, because to a certain extent they cope better with the hot flushes and the mood swings, because they are with many other people in a joint family. Everybody is talking about it. They know what to expect for a couple of years, and then they are having the seeds and all, flax seeds, this, that. So the natural methods, because otherwise spending like 2,000 3,000 rupees per month on hormone replacement is difficult in an Indian scenario.
Right. So we're still with the endocrinologist, Dr. Altamash. So can an OCP cause diabetes? And if it does not cause, can a person with diabetes safely use an OCP? Am I audible, Altamash?
Hi. Yes, you're audible,
Yeah.
sir.
Yeah.
Yeah. So I think I would like to take up this question, answer in this way that yes, OCPs, particularly, especially the older formulations, the older molecules which were there with high estrogen doses, they have the potential to increase insulin resistance. Now, that is one of the.
I understood that estrogen improves insulin resistance, sort of reduces resistance or improves sensitivity. And progesterone is bad.
From older OCPs to the newer OCPs, I'm coming to that order. So the older formulations particularly had this issue, and then they used to reduce the glucose tolerance and others. And especially in women, those who had either a family history of diabetes or pre-diabetes, for example, susceptibility, individuality in that particular woman, or women with risk factors like obesity or family history of disease. Now, what we see is a change in difference of OCPs, whether they would cause diabetes or not. So I think for women with pre-existing diabetes already, modern low-dose combined oral contraceptive pills, they are better because the glycemic control may be stable in them and there are no significant vascular risk factors. If we look at a POP or a progesterone-only pill, or a long-acting reversible contraceptive, LARCs, then these are generally safer alternatives for those with complications like hypertension, nephropathy, or retinopathy, which means if there is a microvascular complication of diabetes, or there is a comorbidity like hypertension, we cannot use all the contraception that is already existing in the literature for them. And if a woman has got tendency towards increased thrombotic risk, then in those cases, estrogen containing contraceptives should be avoided, especially if they have established risk factor or vascular complications. Also, this needs to be individualized. The way we would individualize a diabetes treatment, the contraception for a woman with diabetes also needs to be individualized depending upon her risk assessment, which is also critical to safely do that. Now, the question is then, what are the red flags? So this is, I thought I would also add in this. The red flag that we should look at is especially women, those who are struggling to get their HbA1cs down, especially if the A1C is more than 9, for example, then they should prefer not the combined OCP, then they should go for a non-hormonal contraceptive or maybe only a progestin-only contraceptive. But if you ask me one thing, which is safe in diabetic complications as well as in women with red flag, then it is the IUCD, for example, Copper-T device, which is very, very safe at all levels. And WHO has given point number 1 for this, that they have given 5 numbers for various contraception choices. Number one means it can be used in any type of complication of diabetes. So copper T comes as one of the number one when this is the question. This is the point of question, that for any complication, which one is the most safest? This is how we would say that it is then going to be copper T. So various ways, and there are many systematic reviews and meta-analyses published 2018, 20, and 2023. A lot of RCTs regarding the same of OCPs and diabetes, whether it was NHS study or WHI study or WHO study. So they talk about that, yes, even though there were earlier combinations which used to disrupt the glycemic issues and metabolism and diabetes control, with newer molecules and combinations, it is easier to do it and choose your patient, individualize diabetes, whether it is no diabetes, with pre-diabetes, with obesity and diabetes, with microvascular complication and diabetes with macrovascular complication. Clearly, WHO gives those 5 numbers, and I think from that we select and give very, very carefully. Now, the way we select a nephropathy treatment for type 2 diabetes, similarly, we can select an contraceptive for a lady also. So special mention, WHO says number 3 or 4, when there is a microvascular complication like diabetic retinopathy or nephropathy, in them choose safer alternatives. The final word take is that individualize contraception to that particular lady with diabetes.
So by and large, a lady with diabetes without complications, it should be okay for her to take a low-dose contraceptive pill. Is that the final message that we can? Okay. So as we sort of getting to towards the end of this program, let me share, because I've got that information there in the chat box, that we have more than 1,700 doctors across the country keenly listening to all the pearls of wisdom that you are spreading across. Thank you very much, all of our faculty. So we have maybe can we extend the question about diabetes? Let's talk about dyslipidemia. Dr. Vidya, do you think you allow your lady with dyslipidemia to take an oral contraceptive pill? Dr. Vidya? If
yes.
Yeah.
Yes.
Yes.
Okay. With oral contraceptive pill, as Dr. Altamaksh has already said, we will be risk stratifying the patients. Just make sure that their lipids are very well controlled. Yes, I could still give oral contraceptive pills in patients with very well controlled lipid profile.
Okay. And Dr. Mitra, this is a question that has been sent by Dr. Khetani. Should we continue OC pills in patients with mild elevated liver enzymes?
Liver enzymes, I don't think we should give combined pills for liver. That is something, if we follow the MEC thing, there are very few places where we say a no to a contraceptive pill. Well, all in diabetes and what we were discussing, one factor we have to always keep in mind, how important is the contraceptive part? Because if we are only thinking about the diabetes part, what happens if she gets pregnant again? That is going to be worse for her, and the neonatal complications. So that is where, similarly, for every time that, even for liver function test is probably something like, breast cancer, cervical cancer, abnormal vaginal bleeding, liver function problems, is somewhere we say no to combined pills. Very few places.
Yeah, so someone is on a combined pill and the liver function test does show rather mild elevation of the liver enzyme. So do we stop and then recheck after?
Recheck, absolutely.
Okay.
We recheck whether that is the culprit or something else is causing it, rather than blaming only the contraceptive pill. And if that liver condition is getting better, or some, we identify some other cause that's sorted, then she can go back on her pill of choice or whatever we, offer her later.
Right. So quickly, can we just summarize what would be the contraindications to the use of oral contraceptive pill? You did mention possibly. Are these all absolute contraindications? No absolute?
Absolute is like, what we grade as 4, 3, 4 is where we have to really, really think hard, what is which is more harmful for her, whether the disease is more harmful or having a baby is more harmful. So then probably what we first have to rule out is any abnormal vaginal bleeding, whether her pap smears are okay, if she's being treated for gynecological cancers or breast cancers, then we do not give her.
So gynecological cancer will include cervical cancer.
Cervical
do you
cancer,
think?
yes.
So will an oral contraceptive pill harm the condition?
If it is, it depends upon what is the stage. If it's a very early cancer and she's treated, and that is different. But depending upon how far that is on and what treatment, whether she's had treatment before or she's undergoing. And breast cancer, family history of breast cancer, we always have to take a very wise decision. And liver diseases, VTE, and cardiovascular diseases are, we take a family history, her particular history, and, probably needs a lot of digging in. And hypertension, on how many medications she's taking. And
so is hypertension by itself a contraindication? Hypertension?
Yes. Hypertension is a contraindication, but then again, when we say if it's a very young girl and she's had some hypertension which is easily managed, then probably if she's having multiple sexual partners, then we can consider the pros and cons and give her and try and see. So, and BMI of 30 or more, and any major surgery or any period of where she's immobilized, then we don't offer her contraceptive pills. That area of migraine, we are yet to, probably she chooses. And also the combined pill is the postpartum breastfeeding, where we don't give, because that's a hypercoagulable state anyway, and if it's a female child, can have withdrawal bleeds as well. So this is probably some of the things that we say no to.
Right, good. So can we ask our endocrinologist colleagues about the endocrine side effects of surgical conception, a vasectomy or tubectomy? Maybe Dr. Vidya, for tubal ligation, could there be the adverse effect?
There's a study in UK looking into more than 3,000 patients who undergone tubal ligation, and they propose that perhaps they undergo premature menopause and they get menopausal symptoms. But there is no hardcore evidence, and most of the studies point towards both the premenopausal and post-tubal ligation and pre-tubal ligation hormonal profiles are pretty much the same, including LH, FSH, and AMH. The antral follicles might be reduced. There are some studies that suggest that maybe the estrogen progesterone go low when the blood supply is cut off. But as of now, we do not have good evidence that the patients might go through premature menopause. There is one systematic review that suggests that 9% of the patients do get some hot flushes post-tubal ligation, but there's no change in the actual age of menopause.
Right, Dr. Apurva, quickly, in vasectomy?
Yes, so post-vasectomy, there are no endocrine side effects. Initial 6 months, there may be in fact little bit increase in estradiol, but in very few limited studies. But overall, considering meta-analysis of several studies, and after we have so many years of data, there are no endocrine side effects post-vasectomy. There may be little reduction in the prostate function, but of course, there is no increase in PSA. In some of the studies, PSA has decreased, even though this is non-endocrine, but little related. So there is again no increased risk of prostate cancer post vasectomy in men.
Fine. So before we wind up, let me look at the chat box. So again, so there was a question from Dr. Prasad, which asked, do tubal ligation affect ovarian function, which we have taken up, answered. Any issues with implantation when patient is using IUD for long-term contraception, how to counsel and treat such patients, Dr. Mitra?
IUD and IUS both, I think we should, because we are inserting them in.
Sorry, for my understanding. So what is IUD and what is IUS?
IUD is the copper device that we use,
Yes.
IUD, and the levonorgestrel, Mirena, or is
So
the
what is that S?
intrauterine system.
Oh,
That
that's
is-
not a device. Okay.
That's
Right,
a
yeah.
IUS.
Okay.
Because for IUS, the counseling that is used more in the private sector, whereas IUD is used more in the public sector. It is very difficult to get IUD in the private sector nowadays. So basically, with the IUS, the levonorgestrel coil, the spotting, which she's going to expect after the first 4 months or 6 months, is where the real counseling bit comes in. If they're counseled well or they're covered with something else for that period of time, then probably, she copes better, and then she goes to the top of the hill, then she sees the other side, that amenorrhea part comes in, or maybe very less bleeding. But for IUD, they have to come for checkups, and they have to be counseled that it is there for 5 years, 3 years, whichever one they have chosen for.
What about the reversibility? What about the reversibility after you take it out?
For IUDs, that is what it's got an infection rate higher in tropical country. So personal hygiene should be counseled about, and the chances of infection and pelvic inflammatory disease is more in the copper devices, whereas in the IUS, intrauterine system, on the contrary, it is less than the average. So that is an advantage you get. And for copper, especially for diabetics and all, if we are using where, there are so many problems with using the other systems. So copper is the simplest one we can use, but we have to make sure she's not getting infected there with the foreign body, and why the blood sugar is fluctuating, or because sometimes, they are seeing their medicine doctors, endocrinologists, and probably not having a peep down below in the vaginal area. So that is something we can talk about where IUD. And when you talk about implants, that the Implanon is not really taking off well at all in India, because a surgical procedure in the arm to put in a progestogen, it's not working at all. So.
Okay. Fair enough. So final few minutes, maybe we are actually overstepping our time limit, but thoughts on the male contraception. First, Arpan Dev, next Vidya, then Apurva, and then finally, because at the very beginning, Altamash said he had something up his sleeve, which he will tell us at the end. So he will be the final person. So Arpan, anything you want to tell us? Yeah.
I have a very limited experience about the male contraception. Leave out vasectomy or something. I think the main reason we are bothered about that, whether ED, what Altamash tried to tell about masculinity, probably more of ED they are concerned and more reversibility they are concerned. So that is probably, to me, the reason why since 1960 about the contraception, but it went always to the female. Another reason probably Altamash it goes to the female because they become pregnant. We don't become pregnant. That is the problem, because we think that they are going to get all the burden of it. So there are certain medicines which have been trialed. I think Altamash is going to tell 2 particular trial is going on, which is going to be over end of this year.
Okay. So Vidya, anything about male contraception? Dr. Vidya? If not, Dr. Apurva.
Yeah. Sorry. The whole idea of male and female contraception is kind of, there's a lot of stigma around the male contraception. And in a society like ours, I think we have a long way to go before the men accept and take the responsibility, equal responsibility for the child and accept that, yes, I will, have the male contraception instead of my wife undergoing, tubal ligation. I think we still have a long way to go in a country like India, where men think they are equal to women when it comes to caring for children or contraception. So I'm a bit skeptical that it's going to
I
replace
don't agree with you.
contraception.
I do take care
That's
equally.
okay. Okay, right, Apurva. No? Okay, so Altamash, final word is from you.
Sure. Yes, sir. So I think what we are going to see it is that one trial result will come in December 2024, and the second trial which I'm going to talk about is the molecule will be around Jan 2025 or so. I think two important ones. One is called as the NEST and one is called as the DMAO. So NEST is segestrone acetate, which is a transdermal nestoron plus testosterone. And the second
What is that? What is that once more?
Segesterone, SEGES, segesterone
So
acetate
what is that? So that's a progestogen.
with a testosterone.
Okay,
And
so
one more trial, where this is transdermal, and another trial where the oral dimethendrolone undecanoate is being taken, and both have shown promise in A, sperm reduction, B, they achieve near azoospermia in most individuals. Now, the transdermal one has shown nearly 90% suppression of spermatogenesis in 90% of the patient. While as the other one, which is going to come in January, the trial will be released. That will show it will show the effectiveness of suppression of both LH and FSH, which will actually inhibit the spermatogenesis. Now, here lies the question. If we are using spermatogenesis inhibition at 2 levels, what will happen? Is it really comparable to women contraceptives or not? So that we have two good reviews which came in 2023 as well as 2020, where they mentioned that the failure rates of the newer upcoming phase 2 trials were comparable to female contraceptives, around 1.1 to 2.3% per year, comparable. So a lot of burden from the women OCPs and whatever others we are seeing, because it's important that we have a male contraception, because as we all are aging, the early menopause age is easing out to a very early age. That is what we are seeing globally. The overall fertility, the overall age of menopause is coming down. So we should have something shoulder to shoulder. B, is there going to be failure rate? And if it is there, it's comparable. And second is, what about the spermatogenic rebound? Now, for the rebound, the literature says that the sperm count rises above the threshold after initial suppression. It was noted in around 1 to 2% of the participants during trial, and which posed a challenge in maintaining. It's almost like saying that the vasectomy failed, or the barrier method failed, or the coitus interruptus failed. So this is an issue. Now, important thing, apart from the failure rate and apart from the success rate, is there a side effect and a safety concern for the male contraception? Dr. Apandev Bhattacharya sir rightly said that the woman has to get pregnant, but even though the vessel is theirs, the spoon is ours. So we need to see that there is no weight gain in men when we take that. There is no mood changes. Now, with testosterone, the mood is supposed to be more on the on a little more on the heavier side, more on the aggression side. Now, with this, it can change. The fluctuation of mood may not be taken very well with their spouses. Acne may come, suppression of HDL, cholesterol may come. Asian Indians already have a good amount of suppressed HDL. And most important, the word contraception is to prevent pregnancy. But these hormonal can have a side effect of reducing libido also, because they're suppressing the LH-FSH at the level of pituitary. These may
but
be
you're giving testosterone as well for the first one.
Yes,
that's the reason.
Yeah. In spite of that, these fluctuations are possible and may be taken as a side effect. And that's the reason the mood disturbances and early mood related issues led to discontinuation among some men. And that is where the societal norm comes that it should be only the women who should take the control of this. However, in some patients, gastrointestinal disturbances were seen, and increased hematocrit was also seen with the oral version compared to the transdermal version. Now, important thing, when you give any kind of a hormone, whether a male or a female, we look at the cardiovascular side effects also. I think that these androgenic side effects, whatever I said, along with the altered lipid profile, in possible long-term, maybe bone mass, which is also a possibility because of various combination, and long-term metabolic risk needs to be taken, not just about bone health, but also about total body composition needs to be highlighted, both short-term as well as long-term issues. I think these men will not leave us if we do not explain to them the issues that could come. It's almost like saying going like long-term side effects of bariatric surgery. Most of the patients backslash with us, with endocrinologists. They don't go back to surgeons, but we see those things. Now, one more question is there. Is there a potential to replace female OCPs with these two trials? That is challenges and acceptability over a long term, maybe another 50, 60 years it may take to do that. First is the acceptance with the current amount. And I think this is where I would like to conclude that male contraceptives are, of course, there. They are promising, but there is a real life hurdle. They're effective, yes, matching female pills in pregnancy, but they come with their baggage of mood dips, weight gain, libido swings, etc., etc. And that's how the future is hopeful, but we have to be very, very careful as we enter the next year. Over to you, sir.
Sure, thank you. Yeah, so we are sort of on the throes of getting some form of effective and at least in the short term reasonably safe form of male contraception, but it's a long distance off to say, I mean, to see how well it's taken up by the males across different societies. So with this, I would like to draw this session to a close. I think it was attended by almost 2,000 physicians across the country. That was the last count I was provided with. And I'm really very thankful to all our faculty this evening, Dr. Arpande Bhattacharya, Kansi, Dr. Shushmita Mitra, Dr. Vidya, Dr. Altamash, Dr. Apurva, and of course, as always, the team from Intus who take all the pains to arrange this program. So back to the organizers, and a very good night to all of you from my side.
Thank you, sir. It is my great privilege to offer the vote of thanks. First and foremost, I would like to extend heartfelt gratitude to our distinguished speaker, Dr. Bhattacharya, Dr. Sheikh, Dr. Vidya ma'am, Dr. Apurva ma'am, for sharing their profound insight and expertise tonight. Your wisdom not only enlightened us, but also offered a practical, actionable takeaway that will definitely enhance our clinical practice. Special thanks to our guest speaker, Dr. Susmita, for sparing her valuable time and sharing key insights surrounding female contraception. A special thanks to our post-director, Dr. Chaudhary, whose vision and meticulous curation of topics have been the cornerstone of this series. Your leadership has kept us engaged and enriched over the last 26 episodes and constantly providing learning experiences of the highest caliber. I would also like to acknowledge our incredible audience for their active participation. Lastly, a sincere thanks to our tech support team for their seamless management behind the scenes. And thank you all for your active participant support. We eagerly look forward to seeing you in future sessions as we continue to deep dive into advancing the updating the knowledge of endocrinology in day-to-day clinical practice. Once again, thank you and good night to everyone.
Thank you.